Hello, anatomy colleagues. This is Dr. Alsup, and we're finally moving on to the muscles of the upper limb. This is kind of a longer video because we have quite a few muscles to talk about in the axio-appendicular as well as the shoulder region. So we have a lot of learning objectives, two whole slides worth to work through. But I do think these learning objectives are going to be your best friend. They outline the exact things I want you to know about these muscles. Believe me that there is so much more to know about these muscles. And unfortunately, I can't get into every detail. So these learning objectives will tell you what to look for. If I don't tell you, say, to describe a specific attachment point, you don't need to know it. But if I do, and it's in this learning objective, you do need to know. So these are an excellent guide for your studying. And we will start with the pectoralis major muscles, which are large triangular shaped muscles, and their muscle bellies are located in this anterior thorax region. It will have two bellies with two different proximal attachments. You'll have the clavicular on the clavicle, and then the larger one will have its attachment, the sternocostal region will have its attachment on the sternum, as well as those costal cartilages. And these come together to share a common distal attachment at the proximal humerus. I think this illustration has it a little too low. I'd put it a little higher up here. And so since it's attaching on the humerus, it crosses the shoulder joint, and thus that is where it is affecting actions primarily. When both heads, so both the clavicular and the sternocostal heads are contracting together, they can cause adduction as well as medial rotation of the shoulder. So these are going to be pretty powerful movements. When contracting alone, the clavicular head can cause flexion of the shoulder, and then the sternocostal head can cause extension of it from that flexed position. Now, just deep to the pectoralis major muscle is the pectoralis minor. Major means that it is larger than minor, and that is definitely the case. Here you can see pectoralis minor. You cannot see pectoralis minor without reflecting the pectoralis major. The distal attachment of the pectoralis minor is going to be on the coracoid process of the scapula. So it will be moving the scapula, not the humerus. And its major role is to stabilize the scapula during other movements, but it can play a role in protraction of the scapula, which is visible on this image on the right. Protraction causes the scapula to move more anteriorly and away from the vertebral column. And this is an important motion in pushing exercises. But pectoralis minor is not typically the prime mover for protraction. It is this serrated shaped muscle on the side of the thorax called the serratus anterior. This is a strong and powerful muscle. Sometimes you hear it referred to as the boxer muscle because boxers will often have very robust serratus anteriors because they use it so much in punching forward. It is innervated by the long thoracic nerve, which is a unique nerve in that it runs superficial to the muscle it is innervating. And by far the most common pattern for nerves is to run deep to the muscle belly, but that is not the case here. It is running superficial like this, and that makes it susceptible to injury. If you think of, say, a sharp trauma to the side of the thorax region, that nerve would be right there. And so that damage to the long thoracic nerve could cause an injury called a winged scapula. And so what happens with a winged scapula is that the scapula gets displaced. And it generally gives this appearance of a wing, particularly in comparison to the non-injured side. And there can be different causes of a winged scapula. Injury to that long thoracic nerve is one of the more common, which would cause paralysis or weakness to the serratus anterior and thus would cause a displacement of the scapula. Weakness of other muscles or the nerves that innervate them can cause slight variations to this wing scapula. One of those muscles is the trapezius. So why don't we talk about that one now? The trapezius is a very expansive muscle. It takes up most of the superficial and posterior neck, as well as the superior back. And it has three different parts of the muscle, which have muscle fibers running in slightly different ways, so they can play slightly different roles. And because it is so expansive, it has lots of attachment sites. Proximal attachments include the external occipital protuberance on the back of the occipital bone, which will extend to the nuchal line on either side of the protuberance. Proximally as well, it will attach to the vertebrae in the midline. Distal attachments include the clavicle, which isn't very obvious in this illustration, as well as the acromion and the spine of the scapula, and you'll have that in other regions as well. So no, it does not attach to the humerus, so not moving the shoulder joint proper. It is innervated by the accessory nerve or cranial nerve 11. The trapezius plays a huge role in scapula movement, and depending on which fibers or parts of the trapezius are contracting, can produce different movements. So don't worry so much about differentiating which part is doing what, but I just, in general, want you to know what the trapezius can do. It can cause upward rotation of the scapula. Note how the glenoid fossa is going to be positioned in this movement, and that understand how these scapular movements can be important in terms of the overall shoulder joint range of motion. The trapezius will also retract the scapula, so move the scapula back and closer to the spinal column region. And depending on which part of the trapezius is contracting, it can elevate the scapula as well as depress it. Now, the inferior partner in the superficial back to the trapezius muscle is the latissimus dorsi muscle. If you put those two sets of muscles together, the trapezius and latissimus dorsi, they are so expansive that they cover the entirety of the superficial back. The proximal attachments of the latissimus dorsi are axial skeletal structures towards the midline, like the spinous processes of the vertebrae. You do have an attachment on the pelvic girdle at the iliac crest region. And importantly, the distal attachment is on the proximal humerus, actually quite close to the attachment of the pectoralis major. So that is why those two muscles share similar actions, which include extension, adduction, and medial rotation of the shoulder. Moving on to one of my favorite muscles, the shoulder cap muscle, aka the deltoids, the delts. This muscle is thick, it is powerful, but it's actually relatively short, especially in comparison to the muscles we are about to see in the arm and the forearm. There are three separate parts that are capable of contracting together or separately. There is the clavicular or anterior part, indicated in red in the illustration on the right. You have the acromial part or the middle part in neon green. And then you have the spinal or posterior part, which is hiding back there in dark blue. And what I love about the deltoid is that it plays a role in almost every single action that the shoulder joint can do. It is the most powerful abductor of the shoulder. It is the primary abductor. But depending on which parts are contracting, it can play a role in many other actions. So if the clavicular part is contracting, it can flex the shoulder. But if the spinal part is contracting, it can extend. So these muscles are actually, they can be opposing, the parts can be opposing to one another. Similarly, if the clavicular part is contracting, it can medially or internally rotate, whereas if the spinal part is contracting, it can laterally rotate. The deltoid muscle is innervated by the axillary nerve, which is one of the terminal branches of the brachial plexus. And the brachial plexus is the main source of innervation of the upper limb. So we will be talking about the branches of this quite a bit in upcoming videos. All right, lastly, we have the rotator cuff, which is a set of 4 muscles per side that as a unit form a musculotendinous cuff around the shoulder joint. And the tendons will reinforce the fibrous layer of the synovial capsule by actually blending into it. So they're that entwined with the shoulder joint. And these muscles are the main source of stability of the shoulder joint, helping to keep that relatively large humeral head and that relatively shallow glenoid cavity. The majority of the rotator cuff muscle bellies are posteriorly located. And all 3 of these posterior rotator cuff muscles will have their distal attachment on the greater tubercle of the humerus. And so we will start with the most superior one, the supraspinatus, which is located superior to the spine of the scapula. And it is the only rotator cuff muscle that doesn't play a role in rotation. Rather, it will serve to initiate abduction of the shoulder. And we just talked about how the deltoid muscle is the primary abductor. But based on its placement and line of pull on the humerus, it is not effective in beginning the process of abduction. And that is where the supraspinatus comes in. It begins that first 15 degrees or so of abduction, and then the deltoid muscle takes over. Both the infraspinatus and the teres minor are going to be the primary lateral rotators of the shoulder. The infraspinatus is located below the scapular spine, and it's the larger one. And then we have that teres minor that is going to be just inferior to it. There is only one anteriorly placed rotator cuff muscle, and that is the subscapularis. Its body takes up the whole surface of the anterior scapula, and then distally it will attach to the lesser tubercle of the humerus. And the subscapularis muscle is a medial rotator of the shoulder joint. Rotator cuff injuries are fairly common. There is a lot of action and a lot of friction in this area. So a tear or a rupture of that musculotendinous cuff is a common clinical issue, and this can cause some pretty serious instability of the shoulder joint. And if there is inflammation in this area due to the damage or tendinitis of the tendons, that can greatly affect the range of motion that the shoulder joint is capable of. The supraspinatus tendon is the most commonly affected. And if you consider the anatomy in that area, it makes sense. You have this bony roof right above it with the acromion and the lateral clavicle. So in actions where the arm is above the head or greatly abducted, that causes a lot of friction between the tendon and the bone. All right, practice question time, and this is a good one. Which of the following actions of the shoulder joint would remain unaffected by damage to the axillary nerve? And I will definitely have these second order type questions on the assessments. So how I would tackle this, first you need to know, what does the axillary nerve innervate? What do you think? Well, hopefully you're thinking the deltoid muscle. That would be the correct answer here of the ones that we described or that we talked about. So then you need to know what are the actions of that deltoid muscle. And remember, the deltoid can play a role in almost every single action possible at the shoulder joint except for one. So hopefully you remember that the deltoid is the primary abductor of the arm. So that isn't correct. And recall that the different parts of the deltoid can play opposing roles to one another. So it can flex and it can extend. So those aren't correct. And it can medially rotate and laterally rotate. So medial rotation is one of the options here. So let's mark that one out. And that just leaves adduction, which is the only shoulder joint action that the deltoid muscle doesn't play a role in, making this the correct answer, B, adduction. Excellent. Thank you so much for your time and attention.